Good afternoon, everyone, and I'm very much thankful to AIOC and all the my chair and vibrant colleagues. And this AIOC, I definitely chose this topic for a very specific reason. In 7 minutes, what can I say? And I'm really happy to see some young guns here who will be starting off with their practice and making some good decisions. So I'll be keeping it very, very simple and very, very basic. No hi-fi things. Please take some carry-home points from here. I'll just give some of my mistakes, some cases which went wrong for me. Recently, I had a patient, young male with retinitis pigmentosa and an early cataract, and a simple guy, not asking for much things. So a basic phacoemulsification was done, and a hydrophilic IOL was put in the bag. What happened after 4 years? The patient came without any trauma, and this was the picture. That whole of the bag came in the AC with the IOL in the bag. So, what went wrong? We just thought. What exactly happened that in these scenarios, sometimes there is a progressive zonulopathy which leads to this capsular phimosis, and there is unopposed capsular bag fibrosis going on. Finally, what it leads to is a late subluxation of the bag, and then these kind of pictures can be there. So this was simple to deal with, nothing rocket science. The whole thing had to be taken out. We just enlarged the incision, the whole thing was taken out, and then the patient was given an ACIOL. So a simple case, patient had retinitis pigmentosa, and that gave a lesson. So one case is enough to teach a lesson. So you see the whole of the bag will be displayed. This is your bag, the IOL is taken out, and then we did a vitrectomy and then gave a ACIOL. Leave that. So what lesson was learned? That whenever you deal with patients like these, try to prefer a 3-piece IOL and just avoid hydrophilic single piece IOL, so that you can resist the capsular contraction better and the lens stays central for a longer period of time. Then again, as you find a higher astigmatism, first thing, can I do a toric? I want to get a toric done. So is this my first toric? Yes. So a K1 of 46, K2 51, a toric IOL was designed and toric was done. Experts are there to teach you for hours what can go wrong, but then you never know, you are dealing with keratoconus. And then it wasn't a centralized thing, and the whole thing was on the slope. So the visual axis, if it is decentered and if there is an irregular astigmatism, toric IOL is not the choice. So not every astigmatism is to be dealt with toric IOL. So whenever you see your IOL master, see this SD, standard deviation. These SD readings should not be more than 0.2 or 0.03 millimeters, and if it is like that, then it is highly suggestive of something wrong. You might be dealing with an irregular astigmatism, and then go for topography, see what's going wrong, and then decide for the IOL. An old uncle comes, he's rich, he says, I am a Google user. Are there premium lenses? I don't want to use glasses. You say, yes, I'll give you a trifocal. Same thing was done by me, 75, 80-year-old male, mature cataract, heroic surgeon, did a good phaco, and then, ignoring the small myotic people, gave a trifocal. Now he was not able to read. Uncle again came to me every evening. I am not able to read. Okay. So again a lesson learnt. The diffractive IOLs, whenever you have rings, anything, please see your patient undilated also. If it's a very small pupil, no need to jump for a trifocal or a IOL with rings. These IOLs are pupil dependent, and in these, when it will be dilated, you will be proud of yourself, and when you see the patient undilated, I don't want to say some further. Next case, if there is PCR, I have taken a sum of money and I am committed to put a lens. This should not be the feeling in the OT. Have your plan B discussed with the patient. Have your plan B prepared in the OT. So if you have planned the same IOL and you try to put in the sulcus, then you start getting these kind of pictures. This is the patient I saw last week. These are the toric marks. So this IOL was put in sulcus, And with due respect to all the manufacturers, no manufacturer gives you a claim that my lens will be there in the sulcus wherever you put in. So please don't take this message home that this very lens is going to stay in the sulcus with the toricity intact. No, it will not. So IOL decentration will be there, sunset appearance, unhappy patient, all that will be there if you don't manage these scenario perfectly and don't be committed to a particular lens. This patient had a multifocal, see the dangling cortex, it's in sulcus, the IOL is decentered, now it's a mess, how to tackle it? See here, IOL again going this way, vitreous coming here, this is the way to go about. The third picture, do a very thorough anterior vitrectomy, prefer a 3-piece IOL and then always try for an optic capture in order to have a central optics for your patient and a good quality of vision after a PCR has occurred. A myope, -2, -2.5, such kind of people easily come, working in a bank, maybe a teacher, and then they want a cataract surgery done. You did a great multifocal IOL, patient was 6'6", but then he was pathetic, he is miserable. He said, I never used glasses for reading, what have you done, man? Now I can't just read anything. Earlier I was using glasses for distance, but I used to read my newspaper. Now what have you done? So only thing what you lacked here was counseling. You have to learn this, that you need to customize your lens for your patient, seek option for presbyopia correction IOLs, and as the expert said, EDOFs may be a good choice, maybe a trifocal with due respect to toricity. Again, if you omit toricity and put in a premium IOL, it won't work. So customize your choice of lens. This is a tricky affair. I think one meal is required to explain you all that, but then you can have an unhappy multifocal patient after 6 vision if you do not do a proper workup beforehand. A small point is here, angle alpha. So we can have, see my time is up, but we should read what it is. Actually there are axes, the visual axis, pupillary axis and the optical axis, and in between these axes are the angle kappa and alpha. So if you have eye trace kind of equipments, they give you easily how to measure it, but this is the picture I want you to learn, that whenever you do an IOL master, see these things, Px and Py. These are the x and y coordinates of the pupillary axis. You just have to add it, and then what you get is called chord, C-H-O-R-D, chord. So this chord actually tells you if the magnitude is more than 0.6, this patient is not fit. This is an indirect measure of angle alpha, angle kappa. I will explain you, I can explain you later on because my time is up, 7 minutes was not enough for that. But then this is the factor, whenever you have an optical biometry done, please see these readings. X and Y, no signs required, just add them. Normal value is 0.3, but if it is more than 0.6, this is not the choice for you for a diffractive or a ringed IOL. And pictures speak, don't commit this sin ever. Something is hiding, you all can see. Okay, thank you.